Hi everyone, so this video is covering E&M leveling. Like I said in the last video, I'm trying to break everything down really small and manageably, just because I know this is a very complicated portion of coding, and so I want to make sure we're able to all really understand what we're doing. So this video is not going to go into the examples. We are just going to talk about identifying the levels for E&M. So what is leveling? It's a great place to start. So when we talk about E&M and leveling, what we mean is the process of determining the appropriate code from a section of the E&M section. So we looked at that last time, the different categories like outpatient, inpatient, observation, and each of those categories were referring to the same kind of service, but the codes within each section determine the level of complexity of that service. So when we talk about leveling, we talk about picking the code that best reflects the level of complexity. And we do that by identifying those key components. And remember, we underline this because in some sections you had to have all three key components met. And in other sections, you only needed 2 out of the 3 met, right? And then we also had a determining component for some of those codes, which is time. And we can get into that later. But for some codes, you also can use the length of the service to determine which level is most appropriate. But for most scenarios, we look at these 3 components: the history, the exam, and the medical decision-making. And within each of those components, we want to figure out how complex was the history, how complex was the exam, and how complex was the medical decision-making. And once we know all 3 of those, we can decide which level is most appropriate within that category. So that might seem really complicated now, but we're going to break it down even further. Okay, sorry about that. So contributory factors, these are additional factors that are likely documented and can help us also justify a specific level, and can also be used for leveling some specific codes. Most of the time we are going to use those key components, and these contributory factors are never going to be used in replacement of those key components, but they might be used in addition to them. So right now we're going to focus on the key components, but these are also things to be aware of that you might see in some of the codes as well. All right, history. So the patient history could be a very limited part of the visit, or it could be very extensive. It's really going to depend on the nature of the complaint, what brought the patient into the office or to the hospital or treatment facility or whatever it is, and how important their history is in determining their treatment. So there's a lot of different factors that can go into it. Obviously, if you have something pretty minor, you're in an outpatient clinic, you have a scrape on your arm because you fell on the sidewalk, you're not going to need to do an extensive patient history about any previous illnesses, family history, behavioral problems. That might not be necessary. But for more complex issues, you might need to know if there's a family history of cancer or other illnesses, if there's any substance abuse going on, all kinds of different things that could play a role. If you have any kind of history of specific allergies or other health concerns, there's things that could definitely play a role in the decision-making process or the treatment process. And so in those situations, we'd need a much more extensive history. And so the very first, for this key component, we need to figure out how extensive, how complex was the patient history. And so this is the little chart that I made up, and it looks very similar to the one that is in your book. So feel free to use that. If you want to copy it, fine too. And you can put that into your notes in your CPT manual if you'd like. So there are 4 different levels of a patient history. There's problem-focused, expanded problem-focused, detailed, and comprehensive. So these obviously are going from least complex to most complex. A problem-focused history is going to basically just cover what's this initial injury or illness. It's not going to go into a review of their body systems. It's not going to look at any past history or family history or social issues. It's a very straightforward situation. You fell on the sidewalk and scraped your knee. Okay. So maybe it might look at how does your knee feel, but it's not going to go into a bunch of other body systems or organs or anything like that. It's not going to ask you an extensive amount about your family history or anything like that. So that is the most basic level. We get a little bit more complex. We get into an expanded problem focused. So that's still going to be mainly focused just on the injury. And then it might do a review of the system related to that injury. So it might review a little bit more, but it is not going to go into family history, social history, anything like that. It's still going to be very focused, but it is going to include a problem pertinent review of the system. So whichever system is affected. It is not going to go into multiple body systems. It's not going to do anything extensive beyond looking at the injury and then the area that's affected by that injury. A detailed history is going to look at an extended history of the illness. So it's going to look at several different things within that illness. It's going to review multiple systems. So ask a lot of questions about current health status and multiple different parts of the body and, different areas that might be affected, that might be related, that may not be related. And we usually say it's going to be 2 to 9 because a complete system review would be 10 to 12. But anything more than 1 is going to fall into that detailed review of systems. And then the family history, social history, that's going to just review maybe one factor. So maybe they might ask, do you have a history of alcohol abuse or something like that? So it's just going to focus on one factor rather than nothing or a lot. A comprehensive is going to be, like it sounds, the most complex history that we can take. So it's going to be a very extensive review of the illness. It's going to be a review of all the body systems or the majority of the body systems. We're going to want to look at everything. And then it's going to be a complete history. So we want to know all of their medical history, all of their family history. Do we have any social issues going on, behavioral issues that are happening, or social issues, anything like physical abuse or substance abuse or family history of cancer, anything like that. Most of the time, comprehensive is going to be for admissions into like nursing homes or long-term care facilities, but you will see it in an outpatient setting if it is a very complex case, someone with a lot of chronic illnesses, and it's a new patient especially. So that is how we determine the level of a patient history, by determining each of these factors and then fitting them into this chart somewhere. Okay, so the next section is the examination. So we say the history is subjective, and that doesn't mean it's not true. It just means we're relying on the patient's report. We're relying on them to say, this is how I injured myself, this is how I feel, this is what my family history is like, this is what my personal history of health is like. We don't necessarily have any concrete facts to back it up. The examination is, on the other hand, very objective because it's based on what the doctor can see. So it's going to be what they measure, what they see, what they test. It might be a physical examination, and it might be also include things like measurements or lab tests or things like that. So it has the same titles as the history portion, and it does increase in the same amount, the same way we do increasing levels of complexity. So I feel like this chart's a little bit easier to follow, but so we still have problem focused, expanded problem focused, detailed, and comprehensive. So an exam that is problem focused, we are just looking at the chief complaint. You scraped your arm, let me look at your arm. Expanded problem focused is going to be just the affected system, and then maybe one more. So maybe you fell and you scraped your leg, but I also want to look at your knee and maybe your ankle to see if there was some stability issue. Maybe I want to check your pupils, see if you hit your head, something like that. So it's going to be a more limited examination, but it's going to be more than just one specific part of the body. A detailed is going to be an extended examination. So it's going to be anything that is symptomatic and multiple related systems. So maybe it's several different areas within the body that we're still reviewing. And it's anything from 2 to 7 is the way that we're going to specify. So it's more than just what was immediately affected and your actual injury, but it's less than a complete comprehensive examination. A comprehensive examination is going to be the entire body. We want to look at everything. So that's going to be 8 or more body systems. And they usually have to list those out. That's how we kind of know, unless they say a complete examination of all 8 body systems or however they want to document it. But generally, they do list them out. So this is how we determine the levels of examination. So then we get into medical decision-making, which is probably the most complex part of it. But medical decision-making refers to the complexity of the diagnosis and the treatment decisions that the provider has to make after he takes the history and does the examination. This is based on the number of diagnoses, the complexity of the data that the doctor has to review, and the risk of a complication or even death to the patient if they don't treat or solve this issue. So unlike the other 2 sections, they do have a little bit different names for the levels. They have straightforward medical decision-making, low medical decision-making, moderate, or high. And the area that I think is most important to look at is the risk of complication, because usually it follows, if you know the risk of complication, usually the other 2 sections pretty well follow with that. Occasionally it might not, but usually it does. We're looking for 2 of the 3 categories have to be met in order for us to meet this level. So if it's a moderate level of medical decision-making, it would need to be moderate risk of complication and at least either moderate data or moderate diagnosis complexity. And it might be maybe one of those is limited, but at least one of the others needs to be moderate, okay? So the way we look at this for straightforward medical decision-making is going to be minimal treatment options, minimal diagnoses. It's just one straightforward kind of thing. Data complexity, usually none, maybe something very limited. And then risk of complication is none. So self-limited means if it goes untreated, they will be fine. Or they would have very minimal complications if they are left untreated. Low is going to have a limited number of diagnoses or treatment options, a limited amount of data that needs to be reviewed, maybe one kind of test or something like that. And then the risk of complication or death is going to be low. So that usually correlates with 2 self-limited or minor problems, so problems that would likely resolve on their own or would need very limited intervention, maybe 1 chronic stable illness or an uncomplicated acute illness. So they've just come in with 1 virus, or they have high blood pressure, but it's stable. That's what would fall into the low category. For moderate, we are looking at multiple diagnoses or multiple treatment options, there's going to be more data complexity. So more data to review, more tests to review, or more information the doctor needs to know or review prior to making treatment decisions. And then risk of complication would be, or death would be moderate. And so the way that they define that is one, chronic illness with a mild exacerbation. So they do have a chronic illness and they have a small issue with that chronic illness, or they have 2 or more stable chronic illnesses. So those would be 2 chronic illnesses that do not have any exacerbations currently, or 2 or more. They could have 2, 3, 4, or an undiagnosed new problem, or an acute illness with a systemic symptom. So a symptom that's affecting their whole body system. And then high is going to be obviously the most complex level of medical decision making. So it's a lot of diagnoses or a lot of different treatment options, a lot of data that needs to be reviewed, a lot of testing likely has to be completed, and then risk of death is very high. And so then there's some examples there that I'll have you read through. But it's very likely they would have serious complications or die without some medical intervention or decision making going on. So that is how we pick the level of medical decision making, and we call it MDM. So again, 2 of the 3 categories need to be met in order for us to pick. So if it's low, we need to have low risk of complication and at least low data complexity. And maybe it's multiple diagnoses, or maybe it's minimal diagnoses, but at least 2 of the categories need to be met in order for us to select that category. And then time is the other factor that may be used to select a code, and that can be used in place of medical decision-making for some codes, and it's usually office and some other of the outpatient services. If it's counseling or coordination, the code should be from other E&M services, and the time has to be properly documented, and each category has different requirements about how time is documented. So we do have to be very careful when we use time in order to select a level, but it is something that we can use in certain sections. And again, we'll get into some more examples of that once we get into the book. But I really just want us to be clear on what do each of these key components mean? How do we determine what is the MDM? What is the examination complexity, and what is the level of the patient history? Because those are going to be the things that we look at when we are looking at those 3 key components, okay? All right, so I'm going to continue this, but I want to make this a little bit more manageable. I imagine you'll probably have to be looking through your book as you look at this video. You might want to pause it and look at some examples, or you might just have a whole bunch of questions right now. And if that's the case, please go to the discussion and we will get to them, okay? All right, so I will make additional videos with some actual real life examples moving forward. Thanks.